Great. Right. Well, hello everyone, and welcome to the second plenary session of the Health and Care Research Wales annual conference. Delighted that we're starting dead on time. I can see lots of people joining even as we speak. It's just like that point in a real face-to-face conference where you can see people coming in at the back of the room holding cups of tea and cookies and things like that. So welcome everyone. I'm Kieran, Walsh, Director of Health and Care Research Wales, and the focus of this session is a roundtable essentially on the research response to COVID-19 and the pandemic. It's a huge topic. It's difficult, I think, to talk about anything in research at the moment without talking about COVID-19. But in planning this conference, we wanted to have a plenary that was focused on the response to the pandemic, because we think there is so much to learn about research, about the way we organize it and do it and deliver it and use it, and about what we might do differently in future from what's happened over the last 6 months. It has been, all those overused adjectives: extraordinary, unprecedented, incredible. I nearly used the word world-beating, but I think I'll stick away from that adjective. But really a time of considerable learning. A few little housekeeping points. As in the last session, if you want to tweet things from the session, please do. We're really happy for you to do that. Use the hashtag ResearchWales20. Don't forget that you'll be able to watch the sessions afterwards on our website. And by the way, don't forget to go and visit our new website, which has just been refurbished and looks absolutely fantastic. So, as I said, we're going to have a round table, and I'm going to introduce our 6 contributors all in one go, really quite briefly, and then give each of them an opportunity to talk for a few minutes about what they think we should learn from the COVID-19 pandemic. So we'll take perhaps the first half of the session with those initial contributions from our 6 panelists, our 6 contributors. We will then move into an open question and answer and debate. And as in the last session, if you were with us then, there's a button at the bottom to ask a question. If you click on it, you can put your question in. You can also see in that dialog box the questions other people have been asking. And beside each question on the left-hand side, there's a little sort of triangle icon. You can click on that to upvote the question. That's a great way of helping me to see which questions lots of people are interested in. So do ask questions whilst we're having these initial comments, and do upvote other questions, because we'll tend to respond to the ones that come up towards the top of the list. So without further ado, I'm going to introduce all 6 of our contributors and then hand over to them. I'll introduce them in the order in which they're going to make their initial comments. So delighted to welcome Astrid Burrell, who's the patient and public representative on the Trident Trial Management Group, very involved in the work with BRAIN and the work on Huntington's chorea. Also delighted to welcome Chris Butler, who is of course a GP in South Wales, but is also the director of the Clinical Trials Unit in Oxford and the lead on the principal study of COVID-19 in primary care. Also, our third contributor is Angharad Davies, who's a clinical associate professor at Swansea and consultant microbiologist, and our infection lead for Health and Care Research Wales. Fourthly, like to welcome Ronan Lyons, who's the co-director of SAIL in Swansea and a clinical professor of public health at Swansea University, and also very involved, of course, in HDR UK. Fifthly, Lisa Trigg, who is in charge of research and evidence and intelligence for Social Care Wales. And sixthly, and last but not least, Jane Noyes, who's a professor of Health and Social Services Research and Child Health at Bangor University. So I'm going to hand over in a minute to Astrid, and we'll go straight from Astrid to Chris, Chris to Angharad, Angharad to Ronan, Ronan to Lisa, and then Lisa to Jane, and then back to me, and we'll start our discussion. So Astrid, over to you. Welcome.
Thank you. First of all, can I please say that I do not pretend to be an expert on COVID-19 in any way whatsoever. I've been made to feel very aware of my age and vulnerability this year, and I felt somewhat useless and written off. So when suddenly Health and Care Research Wales sent round an email to the involvement community with a request from the HRA for an urgent response to review a COVID-19 study, I wondered if this might be something useful that I could volunteer to do. It was to review and comment on patient information for a research study about a new drug to prevent severe stage COVID-19 pneumonia in hospitalized patients. It wasn't necessary to have direct experience of COVID-19, but essential to have experience of reviewing and contributing to the development of patient-facing information, and to be able to put oneself in the position of a potential participant being approached for a clinical trial. I've been doing this for the past 9 years with Huntington's disease studies. However, the principles remain the same: to make sure that everything is clearly explained, that participants understand totally what they're being asked to do and why, what the implications are, etc., and above all, that nothing can possibly be misunderstood. In this case, I felt that public involvement was incredibly important to ensure that all the patient-facing documents were absolutely 100% clearly written. The participants, after all, would be ill on a COVID ward, maybe wearing an oxygen mask, possibly frightened, not able to see family in person, and of necessity being recruited more quickly with less time and presumably fewer opportunities than usual to consider and discuss the documents with the study team and family. So I offered to help, and a few days later was told I'd been selected, and the work came through instantly. As this was a rapid response trial with a tight deadline 3 days later, I dropped everything and worked solidly for 3 days to get it done, communicating well with the researcher. I absolutely loved doing it. This was a trial being set up by a clinical research company in Scotland on behalf of a small biotech company in France, with a sponsor in Belgium, with a trial to be conducted in the UK, Europe, USA, and Brazil. It made me realise how privileged I was to be playing a tiny part in the huge international cooperation in response to COVID-19. I was relieved to have the feedback from the researcher, thanking me for my very helpful comments, saying the documents were coming along nicely thanks to this process, and she had implemented almost all of my very helpful suggestions. She said she was sure the sponsor would approve of what we had achieved together. On the strength of that successful collaboration, I told myself I would apply for any more rapid response requests that came along, and a few weeks later, another one did. The email from Cardiff came through at 5:45 p.m. with the HRA urgent request for someone to review a research study looking at mucosal immune response to COVID-19. I emailed the researcher at the medical school of a university in London that same evening, offering my help. And to my amazement, at 8:15 the next morning, he sent an email back thanking me and attaching all the documents. So again, I just dropped everything and spent the day working on the study. By 5 p.m, I had sent everything back and received feedback from him. So a review advertised and completed in just less than 24 hours. I don't know if that's a record, but rapid response was needed and achieved. The researcher thanked me and said my feedback was really valued, and he was going to incorporate some of my suggestions to make the patient information sheet more understandable, and he agreed with all my comments for the consent form. He also said it was so useful to have another pair of eyes checking the documents from a different perspective, and that would greatly help how they would interact with their patients for this research. So very positive feedback again. I have found that these rapid response opportunities for COVID-19 give an incredible chance to just slot into someone else's research team for a few hours or days and instantly be accepted, trusted, and valued. Quite amazing. So I hope my experience has highlighted some of the ways that public involvement is important and valuable in COVID-19 research. Thank you.
Thank you, Astrid. That's great. And the rapidity of the process with which research has been commissioned, funded, set up, enacted, patients recruited has been, I think, one of the things that will be a common theme in some of our discussions, I'm sure. Chris, you're next. Shall I hand over to you, Chris?
Thanks very much, Kieran. Pleasure to be here with you all. So I'm, as Kieran mentioned, the chief investigator of the principal trial, which is a national urgent public health trial UK-wide. And I'd just like to reflect on one or two points within the theme that Kieran has asked us to talk about. So what did we learn from the last pandemic, the H1N1 pandemic known as swine flu? Well, in primary care research, and that'll be the focus of what I say, we didn't randomize a single patient. We gave out huge quantities of the drug Tamiflu or oseltamivir for people with this syndrome, but we didn't do that in the context of a clinical trial. And we probably did a lot of harm, and we don't know if we did any good at all. It's a national disgrace, really. However, this time we've done things better, and with the kind of systems working a bit more for us, we were able to get research up and running very rapidly. I was approached to lead this trial on the 12th of March, and we had our first patient in on the 2nd of April. So it was roughly 2 weeks to write a protocol and get all the permissions in place. But it hasn't been smooth sailing for primary care research with this urgent national public health trial. What we're trying to do is to get people at higher risk, over 50 with comorbidities, anyone over 65, into a trial of early treatment in the community. And this is incredibly important because most people don't get to hospital and most people don't get onto ventilators. But all the publicity and all the research so far around the activity seems to be focused on hospitals. And it's curious that Julian Tudor-Hart, one of the most famous GP researchers worldwide, actually practiced in Glencorrigg, South Wales, 1971 proposed the inverse care law, which says that those most in need of healthcare are the least likely to receive it. And now today we're looking at what I might call the inverse care of access to research, which is that those who are most likely to benefit or want to participate in research are least likely to be offered the opportunity to do so. So huge amounts of funding going on to people on death's score, very little going into primary care, and primary care research is not being embedded as it should be in the community and in the minds of the clinicians and patients. So the recovery trial was recruited in hospitals, over nearly 14,000 people, come up with life-saving information around the use of steroids. But as I say, most treatments are likely to have their biggest effect earlier on in the illness course, and we can keep more people out of hospital and help them to recover quicker if we find interventions that work for community care. So in my own practice, somebody came up to me and was talking to me about a patient the other day, and they said, by the way, the person is COVID positive. And I said, are they in the principal trial? And she said, what principal trial? So we've got something to do about embedding research into the brains of everybody, that it's every health and social care professional's role to signpost people to the principal trial. It's a very easy thing to do. It takes perhaps a minute or two to ask some questions. They get screened online. Consent is taken online. Medicine is couriered to them, and they can participate regardless of where they are in the UK, regardless of where they're getting their health care, and follow-up is all online. So it's a truly democratic trial. It's everybody's trial. But so far in Wales, we've recruited 31 people into the trial. And that isn't enough. We need a whole lot more. And so my plea is that we need to turn research on its head, use these mechanisms which we've pioneered to take research to where the patient is, instead of relying on the old tried and tested mechanism of getting the patient to come to where the research is. Thank you, Kieran.
Thank you, Chris. That was great, and there are some really interesting lessons, I think, to be learned from these platform trials and the way they've been set up, and some questions, I think, about how we take that knowledge forward into future, not just into future pandemics, but actually into future research. One practical point, I'd see lots of quotes from people saying there's a bit of background noise and feedback, so I am going to just ask Chris if you can mute when you're not talking. I think it might have been on your channel, but I don't know for definite. Going to go to our third contributor, Angharad Davis. So Angharad, over to you. Okay, I think Angharad, you might be muted. I'm not sure if it's helping anyone else, but I'm seeing from the comments, I think you're on mute, Angharad.
Computer.
Ah, fantastic. I can hear your voice now.
Okay. So
Yep,
I'll
yeah.
just carry on. I'm not sure how many people heard that, but to talk about the perspectives of this on a UK, Wales and local level and how they complemented one another. And to start off by talking about the NIHR Urgent Public Health Group, which I contribute to as the Wales Specialty Lead for Infection. So this was set up at the UK level as soon as the pandemic took off. And the purpose of this was to very rapidly review COVID-19 study proposals, particularly for clinical trials, and identify those that should receive CRN support. And these were then recommended for approval at CMO level. And the criteria for UPH support was that the study was scientifically compelling, that it was feasible in a UK setting, that it had funding, and that it didn't compete with other studies in the UPH portfolio, or that if it did, that there was a plan to mitigate that. And the studies also had to need CRN support. So some very good studies weren't given UPH badging because they were able to proceed perfectly well without CRN input. The group brings together researchers from different clinical disciplines, methodologists, patients' representatives, so decision-making can be very, very efficient and quick. At first, the group was meeting 3 or even 4 times a week, including Sundays. We just had the 50th meeting. Platform trials, which were given UPH approval in the early days, were the recovery trial, the first one, and principal, as we've heard from Chris, and remap cap. And this has all been very efficient, although one obvious disadvantage is that when studies were being reviewed, the group didn't know what other studies might come along for review later. So, for example, a study might be rejected for UPH status because of some aspect, even though its focus was important. But there might turn out to be no other studies in the pipeline on that subject. And conversely, studies might be recommended for approval only for a possibly better one or potentially better one to come along later, but have to be turned down. But this setup did really force researchers to be targeted in the proposals that they submitted. And to date, there are over 203,000 patients recruited to these studies across the UK. And of course, the recovery trial findings, ISARIC and others have been a real boost for the UK clinical research community. So that's at the national level. On the Wales level, I'd like to really highlight what a fantastic response there's been from the HCRW team and everyone in the Welsh CRNs and health boards. Nikki Williams and Jane Goodwin and CRN staff across Wales have really pulled out all the stops and put in a phenomenal effort. And as of Monday this week, HCRW had 65 COVID studies, 43 of them open, with site-reported recruitment of nearly 8,000 patients, although most of those are in secondary care, as Chris pointed out. And this is not to mention a huge amount of hard work going on to prepare for more vaccine trials. And lastly, to move to what this has meant for our model of delivering clinical trials locally in the NHS. Well, setup happened really quickly, within days rather than months, and the strength and flexibility of platform trials have really become evident. These look certain to be a favoured model going forwards. We're learning about establishing consent to contact registries for the vaccine trials and how these have the potential to speed up recruitment. And I had the privilege last week of attending the excellent workshop run by Sue Vale and Anna Roynan-Reid from an Nihr and Bevan Health Board, and hearing how they responded there. They set up their first trial, ISARIC, within 24 hours on the 17th of March. Recovery opened on a Saturday, which was the 21st of March, and they recruited their first 4 patients that same weekend. They were able to introduce 7-day working, which helped involve and support staff who had never done trial work before, but without compromising patient safety because they were supported. And Sue and Anna really stressed the importance of collaborative working and supporting team members, and I'm sure that's absolutely spot on. So we've learned that things can be done quickly. I think this has all generally worked because there was clear central direction on prioritisation, but with strong links to the regions and coordination with local teams on the ground. And it's this coordination that has been really key, I think, together with the commitment and dedication of the research teams in the health boards. Now I'll leave it there. Thank you.
Thank you, Howard. And I'm reminded of something that I think Jeremy Farrar said. Jeremy Farrar, who from the Wellcome Trust said back in April or May, he said for research to be useful, it had to move at the same pace as the pandemic. And that, I think, has been the challenge, particularly in those early months, for the research to move at the same pace. As you've said, the recovery trial, recruiting, I think Chris said 14,000 patients, is a pretty remarkable piece of research effort, which has provided findings that have been used globally. Ronan, over to you. And I think, Ronan, you might be muted as well.
Yeah. Can you hear me now?
Yep, we can. That's fab.
Fantastic. Well, good afternoon, and thank you very much for inviting me here. I'd like to sort of just quickly address 3 points. First one about enhanced policy and research collaboration within Wales, across the UK and internationally. Second one about making data available to researchers. And then the third one on the enhanced speed of publication and dissemination of research. So if I start off first about the enhanced policy and research collaboration. When this pandemic first occurred in Wales, I offered my HDR UK team to work directly for the Chief Medical Officer, Frank Atherton, in relation to the work we do on data linkage. And that was quickly accepted, and I spent my time setting up data sets and linkage. Feeding into the Welsh Government COVID-19 Technical Advisory Group. Having done that for a couple of months early on, I was then asked, would I sit on the MRC's COVID-19 Rapid Research Panel? So I've just spent 4 months on that. That's a panel that met every week. So we would get reviews in on a Friday. We'd spend a weekend going through them. We had meetings every Wednesday and probably spent about £100 million in research. As we were doing that, I sat and I thought, well, it's about time we put in a bid. So we did, based on the One Wales approach we had to research, with a collaboration between Welsh Government, NHS Wales and the universities. We were successful in having a platform study on COVID called ConCovid, and that's helped enormously. I've also seen unparalleled cross-UK research collaboration. Particularly, I'd point out the role of Health Data Research UK, which has been pushing for this and actually feeding into the SAGE group on a weekly or fortnightly basis. And it's quite amazing to see groups which were initially just single universities or single groups. The number of studies now which actually involve multiple universities across the UK is remarkable. We've also been successful, and hopefully we'll hear about that shortly, in a bid to the EU on international work. And the second one is about making data available to researchers. Due to COVID and the unprecedented buy-in from everybody on how to collaborate, there are far more data sets available to the research community. A second part of that is the frequency of the updates has changed dramatically. Many of the data sets that were only available yearly have moved to monthly, and quite a number have also moved to daily. In doing all of this, I want to pay particular tribute to the superb work of colleagues in NHS Wales Informatics Service in making this happen so speedily. They've been fantastic. Colleagues right across Wales have been superb. We now have linked health and social care data, which we hadn't previously. And the last point I'd make out is the enhanced speed of publication and dissemination. With COVID, what we saw was a huge increase in preprints to get findings out before publications are accepted in major journals. We've also seen a huge increase in reports which are directed to policy and practitioners responding to the pandemic. And I just point out to the data visualization that was used by our health minister on Monday on explaining the spread of the pandemic across Wales. That was created with our COVID MRC grant. Many different people fed into that. And there's a lot of complex Bayesian statistics that sit behind it. We've also had much greater scientific engagement with media. So the speed of turning research around has increased enormously, and I'm hoping that is something that we will see when continue when the pandemic finishes. So I'll stop there.
Sort of joke about you not using Excel, but I decided that probably wasn't a good idea. I think we're very sensitive in Public Health England about their use of a spreadsheet. Right, we're going to move on to Lisa for our 5th contribution. Lisa, over to you.
Can I check you can hear me first, Kieran?
Yes, we can, loud and clear.
Yeah, cool, thank you.
Yep.
So I'm flying the flag for social care, and I have 3 quick points to make, and then I'd like to talk a little bit more about engagement in research. So the first point I would make is that for people working in social care, this pandemic has shone such a huge light on the lack of availability of data and information that may exist across the health system. So the really good part of that is that it's increased the appetite in a huge way. So we've just done a piece of work with Walsh Government to look into how we might develop a data strategy for Wales. And a huge part of that has been around the importance of sharing data with SAIL and about finding better ways to inform research and policy and practice. So the appetite for research and evidence in social care, I think, has grown through COVID-19. The second point I'd like to make is really picking up on something Ronan just said, which is not just the speed of publications and the speed of research and the speed of approvals, but the creativity and productivity that's brought to research, particularly in social care. So, there've been a huge amount of applications to UKRI for social care research proposals over the last few months. But also it's really interesting to see how opportunistic and creative people have been about research. So just 3 quick examples. Work SAIL has done to identify mortality in care home residents is something that I don't think, Ronan, we would have done even weeks ago, let alone months ago. The work that you may have seen if you're interested in social care research, that some researchers did in England to look at how care home managers were coping with the pandemic. But the way they did that was take the messages from their WhatsApp group. So they had a WhatsApp group of 250 care home managers, and what they did was analyze those messages to see what the key themes were. So an extraordinarily, I think, creative way of doing things, and also obviously very reliable and valid data. And then a third one is some research that King's did, where they picked up an existing cohort of personal assistants, so the people who work with disabled people who are employed directly by them. They picked up that cohort to find out quickly what was happening to personal assistants during the pandemic. So there's a lot of creativity that's come out of COVID. People recognise the need to do research quickly, so have thought very inventively about how to do that. So that's something we've really seen in social care. The corollary of that, obviously, is this bewildering amount of research that is now available. So there's the LSE have a really nice site that they set up called LTC, so long-term care covid.org, where they're trying to capture all of the research that's been done about social care and long-term care around the world. And it is bewildering. And if it's bewildering to researchers, we can only imagine what it's like for people working at the front line of social care. So thinking creatively about how we help people access research that we're producing is also really under the spotlight, because it's great having all this research, but how do you actually apply it? Finally, what I'd like to talk about briefly, and I'm not going to be able to do it as vividly and articulately as Astrid did, but just quickly talk about engagement during COVID-19 with research. So I'm sure for anyone out there who's doing qualitative research with patients and with people using social care, we've seen both the strengths and the downsides of virtual engagement. So a really good example of a good process is we've been working with Health and Care Research Wales and the James Lind Alliance to look at research priorities for social care across Wales. And we've had a wonderful experience of engaging people online, particularly carers. So this is unpaid family carers who typically struggle to engage in research because it's hard to leave the person you're caring for. But you can maybe be on a Zoom call for an hour or so. The downside of this, great new virtual engagement world is that it doesn't work for everybody. And I was really struck by what Chris said about the inverse care law and how we see research being neglected for the people who use it most. And we can say the same about virtual engagement. The people who most need to be engaged are often the people who have the least ability to engage virtually. So, for example, autistic people can find it very difficult and confronting to engage virtually, but also people without access to Wi-Fi or good internet connectivity. So what we're seeing is that the same groups are often being excluded from social care research that have always been excluded from social care research, and we mustn't lose sight of that. It's very easy to think, hey, it's great, we can get out and talk to people much more easily, but it doesn't work for everybody. So yes, my take-home message is it's unleashed a huge amount of creativity. We need to think more carefully about how to get things into practice, and we need to think very carefully about the opportunities for engagement. So thanks, Kieran.
Many thanks, Lisa. Lots there to pick up on in our discussion. I'm going to move to our final panelist, Jane Noyes. I'll hand over to you, Jane. And just a reminder to people, do keep looking at the questions and upvoting or asking your own questions. So Jane, over to you. And Jane, I think you're muted as well. This is turning into a trend.
I've got 2 mutes on my computer. Can you hear me now?
We can, loud and clear.
Okay,
Thank
great.
you, Jane.
Brilliant. So thanks, Kieran. And you won't be surprised to know that given my Cochrane background, I'm going to try and pull all of the previous speakers' sort of contributions together and think about how we assimilate the evidence, trusted evidence, to inform decision making. And clearly our leaders do need good evidence in order to inform their decision making and think about how best to develop strategies, etc. So I'm going to reflect in relation to the generation and publication of primary studies, evidence synthesis and evidence implementation and uptake. And I think, as a starting point, it's difficult to now conceptualize that the COVID-19 pandemic has only been on our radar for less than a year, and that the response to it, as everybody has said, has been rapid. Funders such as Health and Care Research Wales have prioritised money for COVID, as have global research funders right across the planet. And that has resulted in a huge amount of generation of primary studies. So Cochrane has reacted very quickly. And for those of you who don't know about Cochrane, Cochrane is an organisation that synthesises evidence to inform decision making, to make it easier to make evidence-informed decisions. Cochrane's COVID-19 study register as of October 2020 now has 20,000 primary study references on COVID-19. So that gives you an idea of the magnitude of the studies that have been undertaken. The rush to undertake studies and subsequently publish them has, however, led to both benefits and harms. On the positive front, as everybody has said, that evidence has been quickly shared globally. On the negative front, there have been some strange decisions made that don't follow established principles. For example, the WHO halted an RCT of a pharmaceutical intervention on the basis of findings from observational studies with a higher risk of bias. And following an intensive exchange of views by various academics played out behind the scenes and in the media, the RCT was subsequently restarted, which had to be the right decision. There have also been instances of research fraud, most notably in the Lancet retracted an early observational study when concerns about the validity of the data sources were raised in the media and subsequently upheld. I have some sympathy for the Lancet and Richard Horton, the editor, as the peer review process is not primarily designed to detect research fraud. Nonetheless, public and journalistic scrutiny worked quickly to identify concerns which were quickly addressed, and the article was retracted. Like all health-related journals, my own journal, the Journal of Advanced Nursing, has been inundated with COVID-19 studies, which led the editor-in-chief to write an editorial on the pandemic of COVID-19 papers submitted for publication. The quality and the validity, reliability of manuscripts has been highly variable, with some excellent studies with clear outcomes and recommendations, but mainly studies of dubious validity with unsubstantiated claims. I would also like to just share as a key point that some experience-based papers have also been really helpful. For example, the early papers on how the Chinese reorganized their health system and medical and nursing workforce and practice have been highly downloaded. So moving on to the synthesis, the production of 20,000 studies to date has presented a specific challenge for the evidence synthesis of these studies. And Cochrane has rapidly responded with the COVID-19 Studies Register, prioritizing COVID-19 questions for review, and the application of rapid review methods. And many of you will know that Cochrane has a rapid review methods group. There's been repurposing of Cochrane editorial process for rapid production and publication of outputs, and they have come out incredibly rapidly. Cochrane's editor-in-chief, Carla Serres-Wisner, has led from the front on rapidly repurposing Cochrane to meet with the COVID-19 evidence challenge. And there are many people, academics in Wales, who've contributed to this, and there are active Cochrane groups in Wales, and we have made a huge contribution to producing the trusted evidence. So Cochrane's programme of R&D to develop new methods has also proved useful. Apart from the evolution of rapid review methods, the concept of the living systematic review, whereby new studies are constantly added, has proved an essential tool in an ongoing pandemic whereby new evidence is constantly produced. Across the pond in the US, I've also been working with the National Academies of Science, Engineering and Medicine in Washington, DC, to develop evidence synthesis methods to synthesize diverse sources of evidence to inform decision-making in public health emergencies and response. And this was funded by the US Centers for Disease Control and Prevention. This work was commissioned before the current context, but it is actually it soon became really evident that it was very important for the COVID-19. In pandemics, it's very difficult to deliver randomized controlled trials or any form of trials. So more diverse sources of evidence are required to make decision making. So although this work started prior to COVID-19, its importance soon became incredibly obvious. The sort of topics that we were looking at were such as quarantine, emergency command centres, and conveying public health messages. The report has just been finished, was presented to interested congressional committees in Washington, and if you'd like to have the link to this report, please just drop me an email and I'll send it to you, which nicely leads into implementation and uptake of evidence into policy and practice. And I think everybody on the panel and you out there tuning into this webinar will realise that the global political and individual response to COVID-19 has varied widely at national and individual level. From a research point of view, this variation has created an opportunity for a series of long-term natural experiments comparing, for example, the outcomes and the acceptability and feasibility of required public health behavioural changes in countries such as Sweden, where restrictions of work and personal freedoms have been less onerous than in other countries such as the South Asian countries, for example, South Korea. In relation to the implementation of evidence, sadly, personality politics has frequently trumped the evidence. At times, science has not been taken seriously by global leaders. Of note, there's observational evidence from political commentators that suggest that national female leaders have acted quicker and conceptualized the COVID-19 issues and threats differently to male leaders. For example, Jacinda Ardern, the Prime Minister of New Zealand, is quoted as saying, on leadership, to me, leadership is not about necessarily being the loudest in the room, but instead being the bridge or the thing that is missing in the discussion and trying to build a consensus from there. On COVID-19, she said, if community transmission takes off in New Zealand, the number of cases will double every 5 days. If that happens unchecked, our health system will be inundated and tens of thousands of New Zealanders will die. There is no easy way to say that, but it is a reality, and we've seen it overseas, and the evidence suggests it. And the possibility we must now face it here. Together we must stop this happening, and we can. And then New Zealand implemented the go hard and go early strategy to minimise community transmission. So if you compare Jacinda Ardern's approach to leadership and the political response to other to the COVID-19 pandemic with others, such as in the UK, US or Brazil male leaders, you'll see a fundamental conceptual difference in their response and also their use of evidence. Although I do have some sympathy for leaders where there's uncertainty in the evidence, a lack of evidence, or scientists disagree on the evidence, which they frequently have, and it's been played out in the media. The media have also played a role in conveying misinformation and highlighting the conflicting views of scientists, politicians, commentators, and the evidence. Conspiracy theorists and COVID deniers, both amongst national leaders and the public, have made implementation uptake of evidence challenging. Yet to be established who and how many people, it's yet to be established who and how many people will accept an evidence-based COVID vaccine, for example. But despite the challenges, I want to end on a positive note that the research and evidence synthesis community have rapidly risen to the challenge of COVID-19. Looking forward, we now have more experience of what is known and what are the research gaps. We also have a better understanding of the potential impacts and consequences of COVID-19 interventions on the psychological health and well-being of the population. Pandemics are not a new phenomenon. In Wales in the 1950s, TB was still rife and children were quarantined for up to 2 years in TB hospitals or socially isolated at home, but we've forgotten about it. The key message is that we should not forget the research legacy from this pandemic. We are hardly likely to do that with over 20,000 COVID-19 studies and counting. We've made a huge amount of progress in terms of evidence in a short period of time and have a clear idea of research priorities and ideas looking forward. Thank you.
That is great, Jane. You covered loads of territory there. We've got about 20 minutes or so left, and we have got a whole bunch of questions. I think 12 or so questions already. I'm going to sort of take the questions from the sort of top of the list and work my way down and put them out, and not ask all of our panelists to contribute, but ask if you're interested in a particular question as I talk about it, for you to sort of just stick your hand up or something, and I'll come to you. One of the questions that people have raised is the nature of exclusion, and they've raised it particularly in the context of digital exclusion, which was something I think, Lisa, you mentioned, I think Chris, you alluded to as well. The fact that some people are excluded both from services and access to services and from research and access into research by our increasing assumptions that everybody has a computer and a smartphone and everything. I just wondered if anyone wanted to comment on that question of how we, in the pandemic, have managed questions of exclusion and inequality, perhaps not limited to digital exclusion, and what we should learn from it about, to be frank, the way the pandemic probably plays out most harshly in the most excluded communities. Anyone like to come in on that? Lisa, you first, yeah.
It's a really important question, and you know, the point I made at the end about people who are excluded normally, in inverted commas, are also being excluded now. I think it's good to reflect on this not being this exposing some new learning, although disabled people would say it wasn't new at all. That there are people for whom this has been transformational. That, you know, for some disabled people, suddenly there's an opportunity to be involved in things in a way they haven't been involved in that hasn't existed before. So it's not difficult. It's difficult to generalize, but yes, this idea that everybody has access to a smartphone and also that they have the literacy skills to navigate some of the tools we use. So it's not just having digital access, it's the literacy that you need to use Slido and Mentimeter and surveys and all of the things that we use online. So it's not just the basic technology. Another finding that I've learned very the hard way is that also some of the platforms that we use, even if people are able to access them, Teams is hopeless for people who are trying to use personal assistants to support them through calls. Zoom works okay, but they're not as accessible to everybody as we'd like to think they were. But we haven't cracked how to reach out to people who are always excluded, travelers, people in deprived areas who don't have access. So I think it's really, if anything, shone a spotlight on how badly we do that, in normal times, whatever that means now. But it has to be a priority. How do we reach out, to Chris's point, to the people who need the research and the support most?
Yeah, Chris, do you want to
that
come in?
doesn't answer the question, but just raises more questions, I think.
Thanks, Lisa. Chris, go over to you.
Just to add in there that in the trial that I'm leading, for example, we attempt to do what I say is to take the research to the patient so that people aren't excluded from trial participation by virtue of where they are in the country or by virtue of which healthcare facility they attend. So we can courier medication and trial materials to anybody in the UK and also follow them up online. But for those people who are too unwell or find that challenging, we can do it on the telephone. But we've also incorporated the facility for a participant to nominate a trial buddy, if you like, who will provide data on their behalf. So having that kind of extra help, making the research kind of more friendly and accessible, will go some of the way to overcoming some of the problems that have been outlined. Still a way to go.
Yeah, okay. I'm going to come on to two questions that have come up, which are both really about the longer term consequences of the pandemic for the health and care research system and how it works. So one question that some people have raised and quite a few people have upvoted is really about what the consequences have been so far for research on everything else apart from COVID. And we can say, isn't it amazing that the recovery trial has recruited 14,000 patients and that we've seen 200 plus COVID studies launched and all of that, but it's been done at a cost to the rest of the research system, the research agenda for heart disease, for cancer, for mental health, for all sorts of other areas. And I'm just interested in people's comments on whether they think that's just a blip, whether we can get this back, or whether actually in the longer term it's a real problem, that the consequences of this for the wider research agenda may be quite profound. Who would like to comment on that? I think I can see Jane, and I wasn't sure, Ronan, whether you had your hand up or not. I'll go to Jane first. I think Astrid did as well. Jane.
As a panel chair in Wales, I can comment from a Wales perspective. And I think that Wales is taking a really nice balanced approach with having its COVID-19 specific calls and also as priority areas in our stream. But nonetheless, there is a balance that we will still accept other research studies, and we'll look at balancing the research portfolio in terms of funding decisions. So I think that Wales has taken a very proactive approach to make sure that COVID-19 doesn't dominate the research agenda, but we do get the sort of answers to the questions that we do need for Wales. globally, I mean, like others on the panel, we've all been sitting on these emergency response panels, the MRC, European panels, etc. And there's been a rush to commission research. And I think we need to see the results and findings of that research first and synthesize it, you know, using good Cochrane principles, and see what we know. And then, you know, have a really strategic prioritizing approach looking forward. So other research challenges will come along. You know, I think there's a lot of complaints from other areas of the research communities now that especially the charities, that their income is now significantly down to commission research. So I think that there will be long-term implications, because you know, there's a small pot of money, there's no more money. If we divert too much onto COVID, it will definitely be at the detriment of other things. I think that the charities who commission condition-specific research are going to be really hard hit in the future if they don't have reserves to draw on. So it will pan out in the future as to what that impact will be.
Great. Ronan, over to you, and then I'll come to Astrid.
Yeah, just joining in. I think there are two big issues. One is the fact that a lot of research that involves human contact has had to be paused whilst COVID is going on, and the difficulties of restarting that. But I think there's been quite a lot of imagination about how to do things differently. I think the thing I'm probably most concerned about is actually just the economy and the tax base. So the research councils, UK government have pumped huge amounts of money into COVID research. Fantastic. Hundreds of millions have been spent. But as the sort of economy stagnates, I think there'll be pressure on to cut funding everywhere. And my concern is that the sort of longer term funding for the research community could be at risk. And, you know, when you've seen what the research community has done to the national response for COVID, you would hope it would be rewarded rather than penalised. But it is something that we really need to look out for. Yeah, that's a good point. Astrid?
I was going to say exactly what Ronan said, actually, that we as the Trident team, I know the team are still working so hard on the trial, so nothing has stopped from their point of view there, but the practicalities of what have had to be done with the patients going for tests and this, that and the other, that of course has been delayed because of the way the health service is at the moment. So it's the pandemic itself that's causing the problem. The patients can't go and maybe have the scans or whatever they need.
Yeah, absolutely. And I think people are also reluctant to go into hospitals or to go to healthcare facilities unless they really have to in the current environment. I think there's also a lot of uncertainty about what's going to happen over coming months. So NIHR and its equivalents in the devolved administrations have been engaging in setting up the restart program that I think Chris referred to perhaps earlier on. But actually restarting all those paused studies is very problematic when the healthcare system is trying to work out whether it's going to have to re-engage with dealing with another wave of COVID cases and hospitalizations. So it's very challenging. Another question that quite a lot of people raised that I wanted to touch on was I think Chris, Chris referred to this, and somebody else did as well. The way in which we've had studies protocols written in 2 weeks. You know, Astrid, you referred to doing your reviews over a weekend. Angharad, you referred to the way in which we've had panels meeting weekly and approving things. The first patients recruited in Nihr in Bevan in sort of under a week for one of the studies is Eric. What can we learn about making the research system more streamlined, more lean, making it work better out of all of this? Is this actually such an extreme case that we can't learn very much from it? Or can we actually learn something that says, well, if typically our time to first patient in trial in the past was 120 days and we've managed to do it in 11 days, we can take some learning back into the process and do something to make it work more quickly, be less bureaucratic, be more streamlined, and yet still have all the protections that people have been concerned to have. Chris, you might like to comment, because I mean you're very much front and center in this running of trials unit.
Yeah, I think the regulators have been very responsive. The Health Research Authority very responsive. R&D departments, so forth, have been, as have sponsors. But I think there is still a kind of lack of pragmatism and lack of proportionality out there in some cases. And I think what the recovery trial seems to have done is that they've just really embedded their trial in routine care completely. And other studies have found that we've been banging our heads against the wall around regulations, for example, of labeling medicines that are wide. So, you know, it's the old story. I'm able to prescribe a medication and give a patient a box of medication and write their name on it when I'm a GP in Kumtaf. But if I want to do that in a trial, I can't, even if it is doxycycline that I bought from the pharmacy. So this sort of sort of impractical or double standards that you sometimes find when it comes to stacking the cards against research is still there. And you know, as you say, Kieran, the challenge is to take the lessons from this. How can we make research more part of routine care in both health and social care, so that it is embedded? It's part of people's mission. They're mandated to do that. They're given the time to do it, but we're not setting up huge mountains of forms and bureaucracy and stuff that makes it just impossible for them to do it. So it's that question of proportionality. I still think we've got a way to go there.
Yeah, I think I would probably agree. Pretty much anyone who goes through the ethics and governance process probably has some degree of agreement with much of what you've said there, Chris. Anyone else want to comment on that question of what can we do to make research work better, to streamline it and better integrate it? Go on, Ankara.
Can you hear me? Yes, can you hear?
Yep.
Yeah. So I mentioned in my little presentation that Nihr in Bevan, for example, Health Board had been able to set up their first trial within 24 hours, and they moved so quickly. So, which demonstrates that that is possible. But I think we have to be careful not to fall into the trap of thinking, oh, we can do that all the time, because to do that, they had to pause over 100 other studies that they were running. So, and there is great concern now going into this winter about the ability, as Chris, I think, has already mentioned, the ability to cope with a second wave of COVID, run the UPH studies, run the Restart programme, which is ongoing, and vaccine trials. So I think that it's great to say, oh yes, we set up a trial in 24 hours, but that does come at a cost, which is not necessarily sustainable. And the other thing about that is that I absolutely second what Chris said about it. A lot of this is about design of trials, and the design of the recovery trial, for example, was made it possible to recruit so many patients and get results out so quickly. And I'm reminded of the ISIS trials back in the 1980s with heart disease, and perhaps we need to look at our trial protocols and go back to those, exactly as Chris said. I agree with that completely.
Simple.
That's great. I'm conscious we've only got a couple of minutes left. There was one other point that's come up in the questions that I wanted to raise, and unfortunately it's quite a big issue, but it's about speed of publication and the way evidence is getting into policymakers, but also into the media and into the public consciousness, and whether or not the way that, you know, the preprint system has completely bypassed peer review. We've seen, you know, incredibly rapid dissemination of findings from studies with very limited oversight. Has that been a good thing? Have we ended up with a problem that we've just got a morass of evidence that we can't make great sense of? And what might be the lesson out of the pandemic for how we do rapid but reliable research, publication and dissemination? And Jane, I mean, obviously with your Cochrane background, you'd have a view on this, I know. So I might come to you, but I just wonder if any of the other panelists want to say anything before I go to Jane. Ronan, yeah. Ronan, you've been very much in
Yeah, no, I'm saying I think it has been a very good thing. There may have been a few errors, but actually getting a lot of that evidence out has been helpful. Vast majority of preprints did stand up. The one thing I'd point out to it also is the live systematic reviews. If you look at this week's JAMA, the WHO systematic review of steroids actually included all the data of all the trials before they were even printed. I mean, that is absolutely remarkable and a very high quality activity. So whilst there's some downsides, I think most of it has been positive.
Yeah. Jane, would you like to come in? And then I'll come to you, Lisa.
Yes, I'm just checking on every channel that I'm not muted, so I'm fine to go. So I would agree with that. Cochrane is even including trial study data in reviews that is pre-publication. These are all new methods that have been brought online very rapidly. The one thing I would say is that the journal editors have been inundated, and there's a lot of peer reviewer fatigue. So even when they do get to peer review, I think that we need more peer reviewers, or we need to encourage people to publish less, to only publish key evidence, or we ask them to have different forms of publication. Why not put it on an open forum somewhere, the National Science Framework or the Open Science Framework? Why does it all have to go in journals? Again, that doesn't help with the discrimination of good evidence versus unreliable evidence, and we're still trying to crack that one. I think that the fact that research fraud has been picked up pretty early, even though the studies have been published, is a sign that the scrutiny that's put on these papers, either by the peer review system or the wider scientific community, is there and it is happening. It's a monumental feat to synthesize all this evidence, and I think there is something to be said about the burnout of the reviewers as well. None of us can continue working at this level forever. It's like the clinical frontline staff. You can only do this level of work and this hours commitment per day for so long before we all become burnt out as well. So we do have to go back to some sort of normality pretty soon.
Yeah. Good luck with going back to normality. But Lisa, do you want to? I think this might be our final comment, given time.
Okay, I'll make it quick then, Kieran. I think it's about being pragmatic, isn't it? When it comes to clinical trials, there are very good reasons why there are such important processes and protocols around peer review. But I'm minded of the study that the LSE did around mortality in care homes that came out, I think, very soon after lockdown, which alerted everybody to the issue that in countries in Europe, half of the deaths from COVID were actually in residential care. So I think it's about being pragmatic. The other thing I'd say about reviewer burnout is knowing the authors of that paper, a lack of peer review also puts a huge pressure on the researchers. They were so concerned that they hadn't quite got it right. What they said did come to bear. But I certainly think that it's introduced some pragmatism about what's important to get out there quickly. And it's not a generalizable observation, either way for all types of paper. And that's where this pragmatism should come in.
Brilliant.
Thanks, Kieran.
Thank you, Lisa. We are out of time. We'd normally at this point have a round of applause, but you're going to have to take that as read, I'm afraid. But thank you to everyone who's joined the plenary, and thank you to our 6 panelists. In fact, there's a really great link from what we've just been talking about, the use of evidence, the challenges and so on, into our next plenary at 2:00, which is absolutely about working with policymakers to get research and evidence used. And I know Steve Martin and Paul Kearney, who are presenting in that session, are both going to draw in some of the lessons around COVID. Steve runs the Wales Centre for Public Policy, which works very closely with Welsh Government, and they, like many of us, have pivoted towards doing work to support policymakers around the pandemic. So I'm sure he'll have some comments to make about this question of using evidence effectively. So thank you, everyone. Thank you to everyone who joined the session. Chris, did you want to say something before I think? No, you're just saying a farewell. Right. Okay. So thanks, everyone.
Thank you.
And see you again at 2:00.